Okay, so ultrasound contrast agents been around for quite some time. We started in late 60s with hand-agitated saline when we just connect 2 syringes of saline and run them through the stopcock, creating small microbubbles. And believe it or not, lots of echocardiography practices still use this agitated saline to look for holes in the heart and also to pacify ventricular chambers looking for wall abnormalities. We moved to several generations of contrast agents, and now we are most of our contrast-enhanced ultrasound is performed with the second generation ultrasound contrast agents that microbubbles with different shells with heavy gases inside. Microbubbles that are available now in the market, they all come with different shells. They can have lipid, albumin, or polymer shells. Diameter of microbubbles is somewhere from 2 to 10 microns, but all of them are about the size of the red blood cells, meaning they will go where red blood cells go, but they will not leak into interstitium, unlike contrast agents used for CT and MRI. We administer microbubbles through intravenous injection. It's not recommended for intraarterial injection, so please don't do that. Some people do intracavitary injections of microbubbles, and we'll talk about those applications in a little bit later. Most of the microbubbles available on the market dissolve in circulations in about 15 minutes. So if you need an additional injection of ultrasound bubbles per manufacturer guidelines, you can do it. You just need to watch your dose, and you can characterize several lesions in one study with 2 different injections. Shells are breaking down by the liver, and gas is excreted by the lungs. So why do we see microbubbles? At very low MI, microbubbles behave differently from normal tissues. At very low MI used for contrast-enhanced ultrasound imaging, normal tissues will have very organized response to acoustic pressure. Normal tissues will expand and compress at the same rate. Microbubbles will behave very differently. They will produce a ton of harmonic signals, so they will expand a little bit more than contract. So what you end up with when you scan patients at very, very low MI without microbubbles, if you insonate tissues with, let's say, 2.5 megahertz transducer, you get 2.5 megahertz signal back to you. With microbubbles on board, because of this harmonic frequency, you get 2 signals back. You get 2.5 and 5 megahertz back. So if you subtract this 2.5 megahertz using different imaging techniques like amplitude modulation and some other tricks that manufacturers use in their systems, you only end up with the signal coming up from, let's say, 5 megahertz in this case. And then on your screen, you're going to have 2 images. You're going to have B-mode image obtained with very low MI at 2.5 megahertz frequency, and then you're going to have contrast-enhanced ultrasound image right next to you, showing you bubbles and nothing but the bubbles. There are 3 contrast agents available in the market in the United States: Definity, Optison, and Lumason, and we'll go through all of them. I'll show you how to prepare them and administer those contrast agents. Contraindications of all those 3 contrast agents are hypersensitivity reactions and intraarterial injections. We previously had some other contraindications like pulmonary hypertension. It was removed by the FDA from the labels, and right now all those agents are only contraindicated to agents with prior hypersensitivity, and again, we're not recommending using them for intraarterial injections. Adverse effects of contrast-enhanced ultrasound agents are extremely mild and usually extremely well tolerated. Headache, dizziness, flushing occur in every single drug that we use in our practice. Allergic reactions do happen, and sometimes they might be severe. They occur at much lower rate compared to CT and MR ultrasound, CT and MR agents. But still, those are allergic reactions. You have to be prepared. You need to know how to treat them. So obviously, we only recommend using those contrast agents in medical facilities with appropriately trained personnel. We do have crash carts in the rooms where we inject ultrasound contrast agents. So for all practical purposes, treat them exactly the same way you treat CT and MR contrast injections. Some patients complain of metal taste in their mouth when we inject. I think it's just from the saline flush that we use to follow our bolus injection. In 15 or 18 years I've been doing this, I had 2 patients who developed renal pain or back pain. It's very short lived complication or adverse reaction of contrast injection. There is something with bradykinins releasing from the renal cortex when you inject lipid-based microbubbles. All of those back pains or renal pains go away in about 1 to 2 minutes. So if you see a patient who is complaining of back pain right after contrast injection, know it will go away. Tell them it's usually not severe, uncomfortable, but if you know that this is very temporary, you can comfort the patient and all those pains and aches in the back go away. And again, it's extremely uncommon. We had only 2 cases in 15 years of doing this. Okay, so let's go through contrast agents because all of them are slightly different in terms of preparation, and I'll show you the differences between them. Lumason is a very commonly used agent on the market. It comes in this dry powder at the bottom of the vial, manufactured by Bracco Imaging. Those are the indications that you can find on the insert of this agent. It comes in a kit, and kit contains several different components: vial of the Lumason, syringe of saline, and very, very, very important piece of this kit is a spike that will allow you to draw and inject contrast back into the vial without changing pressure in the vial too much. One of the very important things to pay attention to, all ultrasound contrast agents are very sensitive to rapid changes of pressure. They will burst if you increase pressure in the vial too much or create too much vacuum. So using some kind of spikes or venting your vials with needles, especially in the beginning, is very, very beneficial. Later on, when you practice, when you know exactly how to handle ultrasound contrast agents, you might not need to pay as much attention to it, but I would strongly recommend using those spikes and vial venting techniques early on. All right, to prepare Lumason, you just open this kit. Again, it comes with a vial of Lumason, chemo spike, and this syringe that comes in 2 pieces. There is a syringe itself and the plunger that comes as a separate piece. After you take everything out, I usually start by assembling syringe. You just screw the plunger into the syringe and you break this cap of the saline syringe. Leave it alone for a second. Then you open chemotherapy spike. And there are 2 green pieces that need to remove. One is on the spike itself, and then the second one covers the attachment for your syringe. You can do it in any sequence, but I usually attach my syringe to this chemotherapy spike, get it into a vial of Lumason, usually resting Lumason on the table because that chemotherapy spike is pretty thick. You need to apply decent amount of force to get it into the vial, and then you slowly inject saline into the vial. Okay? It's pretty easy. Takes seriously 30 seconds after you know how to do it. And then you vigorously shake vial of Lumason, reconstituting microbubbles. While I'm shaking microbubbles, I always turn the vial upside down, looking at the bottom of the vial, making sure that all agent is reconstituted. And you're going to end up with this milky solution in your vial, which is ultrasound contrast agent. To aspirate, we use the same syringe we use for reconstitution. You just flip the vial open, draw whatever amount of contrast you need for the injection, you're pretty much done. On occasion, you might end up with a small bubble of air in your syringe. Using this spike, it's safe to inject this air bubble back into the vial of the Lumason. If you need additional agent, just draw it in your syringe. Injection, we always use stopcock. This is the line that goes into the patient. And one of the most important things that we do on every single injection, we flush the line first. I always test my IV line before I inject Lumason or any other contrast agent, because you need to make sure that there is no clots, the line is open, and everything flows nicely. After you flush it, you tell your sonographer to start the clock, and you inject Lumason. We usually inject contrast agent over 2 seconds, flip the stopcock back, and then flush it with your saline, okay? Both of them are injected at about 1 to 2 ml per second. Don't do very, very, very slowly contrast injections because you're going to ruin your bolus. It will not enhance the tissues as nicely as you would with short, quick bolus injection. And then don't hammer your saline because this will create too much pressure in your line. You can burst your microbubbles. So nice and gentle, but also quite quick. If you leave Lumason sitting on the table, I don't know if it's projecting well, but it will separate. They're going to have a little bit more microbubbles floating at the top, that at the bottom. All you need to do before aspiration, you just gently shake it, reconstitute microbubbles, and you're pretty much done. You can do another injections and proceed with your examination. Definity is a different contrast agent. It comes as a clear solution of lipoproteins with heavy gas floating at the top of the vials, manufactured by Bracco. Those are approved indications of these agents. It has to be activated to turn from clear into this milky substance, and you activate it using this device called vial mix. It used to be used for amalgam mixing for dental work, and now you can use this for Definity preparation. All you need to do is to put the vial on top of this mixer, hit the start button, and it takes approximately 45 seconds to activation. We speed it up a little bit, so I'm not having seizure behind this, but 45 seconds after you start activating Definity, it will again turn into this milky substance, and you can use it for your contrast-enhanced ultrasound examinations. We do vent vials of Definity. You don't have to if you know exactly what you're doing, but in the beginning, it's very beneficial to do it. We use 2 18-gauge needles. One goes all the way to the bottom of the vial of Definity. Second one we put just under the Definity cap. If you have this contraption with 2 needles, the one that you put all the way down will be for venting of the vial, releasing the decreased pressure after you aspirate this agent, and this guy you can use for contrast aspiration. Again, you don't have to do it, but I think it's quite beneficial, especially in the beginning. When you need to aspirate Definity, you just flip the vial open, connect your syringe to the needle that sticks out the farthest, and you can aspirate. And again, if you aspirate a little bit too much, you can inject Definity back into the vial. Injection is identical to Lumason. You test your line first, then you flip your stopcock, tell sonographer to start acquiring data, inject your Definity into the line, again, quickly, 1-2 seconds per injection, and then flush Definity with saline. Definity will also separate if you let it sit on the counter for too long. All you need to do with the vial, you again gently shake it, reconstituting contrast agent, and it will be ready for you to inject. Finally, Optison is another agent produced by GE. It comes with this cake of the microbubbles floating on top of the solution. Again, manufactured by GE. Those are approved indications. And this agent is the easiest to reconstitute. It doesn't require any mixing. It doesn't require vial mix. All you need to do is get the vial out of the box, and you gently kind of roll it between your hands, reconstituting microbubbles and also warming the contrast agent a little bit, because Definity and Optison will have to be refrigerated before administration. So that's all it takes to activate vial of Optison. Similar to Definity, it doesn't come with a spike, even though I think Definity now can provide you with the spikes for their contrast agents. If you don't have spikes, that's fine. You do the same thing we do with Definity. You vent your vial of contrast with 2 needles, and it's ready for you to aspirate exactly the same way you would aspirate Definity, using needle that sticks the farthest out from the vial for aspiration, and the second needle that ends at the bottom of the vial to vent it. Injection technique, again, identical. Again, always test your line first with a little bit of saline, then inject your contrast agent over 1 to 2 seconds, flip your stopcock, flush it with saline, and you will be just fine. Optizone also, same as other agents, will separate, so all you need to do is gently shake this vial of contrast agent to reconstitute those microbubbles that will be floating on the top of your vial, and you will be good to go. All right, system optimization to start. One of the most important things to do is to bring your lesion as close to the surface of the patient as possible. It's very important for kidneys and for livers. We try to scan from the back, from the side, putting patient upside down. You do whatever it takes to bring the lesion as close to the surface of the patient as possible. Because most of the patients and most of the systems will probably have some kind of sweet spot over between 10 to 15 centimeters. It will not scan beyond that using normal transducers. So closer to the skin the lesion is, better you're going to see it. Kidney with a large tumor that was ablated with microwave ablation, you can see when it's close to the skin, you can see nicely dark void area of ablation cavity, nicely enhancing kidney. When we scan from the different window behind the spleen, this lesion is almost completely invisible because microbubbles will flow into the spleen, they will shadow. This lesion is too deep, somewhere it's 7, 8 centimeters. There are ribs, there is lung in between. So if you have really hard time seeing the lesions on B mode, there's pretty good chance that you will have hard time seeing them on contrast enhanced ultrasound. So take some time, make as beautiful image as possible, find the best acoustic window, bring the lesion as close to the surface of the patient as possible, and this will be the best place to start with your contrast enhanced ultrasound. Pre-injection display, we always recommend doing it in dual screen mode unless it's necessary to do overlay, so see contrast only. What you're gonna do, we're gonna end up with is 2 screens on your monitor. One will be contrast enhanced ultrasound image, and then there will be B mode image next to it. Since we use very low MI for contrast enhanced ultrasound, your B mode image that you're gonna get as a part of this contrast enhanced ultrasound screen will always be not as good, as beautiful as your normal diagnostic B mode image. Because this image is acquired with a mechanical index of 0.09, and this one is acquired with mechanical index of probably 1.2 to 1.3. So you have significant drop in MI to preserve microbubbles and also to filter them better from the background soft tissues. So use it for guidance, but don't expect it to be as nice as diagnostic B mode. Focal zone adjustments is very important. If you move focal zone close to your transducer, you're going to lose microbubbles in a far field. If you move your focal zone far away from you, you're going to start increasing your mechanical index, ruining some bubbles at the periphery or in the near field. So in a perfect world, you want to have your depth of scanning somewhere slightly deeper than the lesion, and you want to have your focal zone at the bottom of the image or in some systems at the bottom of the lesion. So pretty much keep your focal zone close to the lesion, slightly deeper with smaller field of view and smaller depth of scanning at the bottom of the image. So if you end up with something that looks like this, when you have lots of bubbles in a near field and almost no enhancement in a far field, take a look at your focal zone. It's probably too close to the surface. Contrast gain is also very important. If you decrease it too much, you're going to lose your microbubbles. But more importantly, don't increase it too much because you're going to end up with pseudo-enhancement in cystic lesions, like in this case. So we always try to find some kind of happy medium when we don't see pseudo-enhancement in the lesions or areas where you're not supposed to see microbubbles, but also we really don't like those overly bright blooming displays because every microbubbles will have halo on top of it, and you can turn benign cystic lesions into something suspicious. Imaging protocols are very, very important as well. So when you just inject microbubbles, or let's say before you inject microbubbles, this is a decent image. You're going to have a little bit of noise, bright lines from very, very bright interfaces. And we almost always see those bright lines on the surface of the liver, somewhere in the skin, on the surface of the muscles. This is totally, totally appropriate. You want to see maybe minimal amount of noise in the liver itself, just to gauge your gain adjustments, but you don't want to see too much brightness in there. You don't want to see anything moving or flowing in the contrast-enhanced image before you administer the microbubbles. So after you inject microbubbles, right after injection, nothing happens. And this is totally, totally fine. And I know people, when they start, try to panic, try to adjust the buttons, increase the gain, or do something. Don't do anything, because it takes 10 to 15 seconds for microbubbles to get to the liver. So I don't even acquire images at this phase. We start acquiring images when we start seeing first microbubbles arriving into the tissues. So that's where you start acquiring your images. You see nicely enhancing arterial hepatic arteries, portal veins, then enhance after that, leaving hepatic veins relatively unenhanced, and then slowly you're going to see contrast enhancement in the hepatic veins, filling the entire liver with contrast, leaving this small tiny cyst that I include in this image for reference unenhanced. Contrast-enhanced ultrasound has an extremely high frame rate, somewhere from 9 to 15 frames per second, much higher than any other imaging modality that we can use to image the liver. So you're going to have very beautiful phases. You can track them with the hepatic arterial phase, then portal venous phase with enhancement of the portal veins and dark, unopacified hepatic veins at this point, and then late phase with filling of the entire liver with contrast. However, after you get to peak of arterial enhancement, or sometimes recommend scanning up to 1 minute in patients with cirrhosis with delayed arrival of the contrast into the liver, you have to stop, because we want to preserve as much microbubbles as possible to detect late washout. Microbubbles are susceptible to ultrasound beams. They will burst if you keep scanning large areas of highly vascular lesions or organs like liver and spleen. So we always recommend stopping your imaging right after at the peak of arterial enhancement, or sometimes at 1 minute, and then we go back every minute, every 30 seconds for only 5-10 seconds, quickly scanning the lesion, acquiring couple short cines or couple still images, and stopping the acquisition until next minute. So at the end, you should end up with a cine of some sort up to peak arterial enhancement or up to 1 minute, and then couple short cines or still images obtained. We usually do every minute to look for late washout of the lesions. Renal imaging is basically pretty much the same. You inject bubbles, nothing happens. Kidneys usually enhance a touch faster than liver because there is just more blood flow going to them. But again, if you see nothing in the beginning, that's totally fine. Then you're going to start seeing contrast in the aorta, and immediately after that, kidney will enhance. Cortex will enhance first, medulla will be relatively unenhanced for a few seconds, and then you're going to see complete filling of this kidney with microbubbles. Again, fantastic modality to use. You can see all the phases, arterial, cortical, and medullary phase, and the protocol for kidney imaging is pretty much the same. If we can characterize cystic renal lesion in the first minute, saying that there is no enhancement of any solid components within the tumor, you can stop. If you see it's a solid mass and you want to see if there is a washout or not, do the same thing we do for liver. Do arterial phase enhancement, cine loop for 30, 40, 60 seconds, and then the stop, and you can go back every minute for about 5 seconds to get images that you need. When you start contrast-enhanced ultrasound, you might scare your PACS administrators with the amount of data you produce. Tell them that this is about the same as good MRI, so they potentially will leave you alone. If you absolutely have to decrease your amounts of data that you're producing, you can drop your frame rate, and this will make significant contributions to the space that you're occupying on your PAC systems. CineLoop with 9 frames per second can produce up to 300 megabytes. If you drop it to 1 frame per second, you can end up with only 44 megabytes of data. It does ruin the joy of scanning to some degree, but you can produce decent images even with a very, very low frame rate. Those are the few examples that you can, just to give you an idea of what amounts of data you will produce. Liver exam, grayscale, color Doppler, 1 contrast-enhanced ultrasound injection, and then microbubble destruction sequence will produce 600 megabytes. 2 injections of contrast-enhanced ultrasound, 780, and then if you do more and if you prolong your CINES, you can end up with 1 gigabyte of data. But again, MRI can produce close to 500 megabytes of data as well. So if your PACS administration complains too much, send them back to MRI, and they'll stop almost immediately after that. Contrast-enhanced ultrasound is not free of artifacts. I'm just going to quickly run through them so you know they exist and you know how to avoid them. Majority of them come from B-mode artifacts that we see with B-mode imaging, but there are also some artifacts that occur specific to contrast-enhanced ultrasound. Shadowing, if you inject contrast and then you scan something behind very, very large vessels, microbubbles, densely populated areas of microbubbles will produce some shadowing, so you might not see lesions behind large vessels. Loss of enhancement in the far field. Some of the scanners are better than others, but most of them will kind of have these hazy, dark areas at 10 to 15 centimeters. You can alleviate this by decreasing your probe frequency, going to penetration presets on your scanner, so decreasing your dose of contrast, so there will be less shadowing from the vascular areas. Posterior acoustic enhancement and the cystic lesions can also produce very, very bright signals on contrast-enhanced ultrasound. Also, not an enhancement, just an artifact, because you can see identical thing on the grayscale image. Mirror imaging happens on occasion, again, similar to B-mode ultrasound. You have this nice hemangioma in the liver, and then identically appearing hemangioma in the lung, which is obviously not true, it's just mirror image artifact. Reverberations that we see on pre-injection display can also occur on grayscale and contrast-enhanced ultrasound images in this dual screen display. Do not call them enhancing septations in the CIS. Those are just reverberation artifacts. All those nonlinear artifacts, again, non-pre-injection display, are completely normal. I personally use them to adjust my contrast gain because ideally I want to see almost nothing in the liver, but I do want to see something along the very, very bright surfaces to tell me that my contrast is not set too low. There is a very important artifact that I want to spend a little bit more time talking about is nonlinear pseudo-enhancement that happens in the very, very bright areas of the lesions, and it ruins our life when we look at lesions treated with TACE or some kind of thermal ablation. Normally, TACE patients or patients with appropriately treated lesions will have completely black holes. Let's see if it plays. Yeah. You can see this lesion, and then we inject contrast agent. There is absolutely nothing inside of this lesion, confirming complete ablation of this mass. The problem happens when we see lesions like this. Immediately after TACE procedure, we deliver some gel sponge into the lesions, producing this very, very, very bright echogenic reflectors. So sometimes we have calcifications or something else depositing in those ablation cavities after procedures. And you can see some artificial enhancement in those cavities. The caveat is it happens late. And you see in the arterial phase, all those bright areas pretty much devoid of contrast. There is probably a vessel running through. But when you build the microbubbles in the surrounding areas, those areas with bright echogenic reflectors in the tumor gonna start showing you fake contrast enhancement. Don't call it recurrent tumors, it's just nonlinear reverberation artifact and pseudo enhancement in those very, very, very bright areas. Give them some time, those reflectors usually will decrease over time, and this pseudo enhancement artifact will dissipate with them. Okay, sometimes if you have very, very bright lesion to begin with, like this AML in the kidney, you might see some brightness in there on pre-injection display, and of course this will persist on post-injection. Decrease your gain a little bit, you will see this artifact disappearing, and when we do renal imaging, we don't really need to increase our gain because kidney enhances so brightly, you don't need a ton of gain to see microbubbles. So if you're not sure about this, if you don't like it on pre-injection display, just drop your gain down and you will be fine. If you scan livers or vascular organs for long periods of time, because of the higher MI in the near field, you might end up with those bands of decreased signal in the livers. We call it near signal loss. Just know it happens because of your continued scanning. Drop your MI, scan slower, take more breaks between your imaging and to avoid this artifact. Also, if you scan for too long in one plane, like in this liver, when you turn 90 degrees to that plane, you might end up with those bands of decreased contrast enhancement, because some of the microbubbles will stick to the vessel wall, they might retain in the sinusoids of the liver. If you burn them all completely, they might end up with those bands of decreased signal enhancement. Again, no, this is not a washout in a massive amount of liver, it's just you scanning for too long, too stationary. You need to take a break, move your transducer around to make sure those bands don't happen. And also, we also need to worry about pseudo washout that happens in very vascular, with vascular tumors with very slow flow, like hemangiomas. If you stay on this nicely enhancing hemangioma for too long, you will break too many bubbles within it because lots of them will be flowing at a very, very slow rate, so sometimes getting stuck in the lesion in non-perfused vessels. And if you stay in the lesion for too long, you might ruin your microbubbles. The best way to avoid this artifact is to re-inject the patient and not scan until 4 to 5 minutes. Let microbubbles circulate. If it's true washout, when you go back to this lesion without scanning 5 minutes after contrast injection, it will demonstrate washout. But if it's a fake washout after re-injection, you will not see washout, and they're preventing you from calling this lesion a malignant mass. And finally, talk a little bit about dose of contrast. Manufacturers all have recommended doses on their packages, but quite often with newer scanners, with more sensitive transducers, and with the skinnier patients, those doses might be a little bit too high. So honestly, we almost never inject full dose of contrast recommended by a manufacturer. We almost always inject less than that. And if you inject a full dose, you might end up with those images that are oversaturated. If you have too much bubbles on board, you're going to start losing your contrast enhancement because of the shadowing in the far field. If you inject too little, you're not going to have enough enhancement, and you're going to ruin those microbubbles quite quickly. You might not have enough time to see delayed washout that in livers might happen 5-6 minutes after contrast injection. So gauge your contrast dose based on your patient, location of the liver, and also sensitivity of your scanners to end up with images that look like this. When you see everything you need to see, you see vessels and parenchyma, you can also see enhancement in the far field. Couple resources for you. AIUM have contrast enhanced ultrasound community that have meetings quite often, and we kind of gauge the educational component of the AIUM. So if you're interested, you're more than welcome to join us there so you can have a voice on what educational content you want to see at this conference. ICAS has a fantastic website that's been recently updated with a ton of information on protocols and case reports and whatnot. European Societies of Ultrasound in Medicine and Biology produced very, very nice guidelines. So if you're just starting, that's a good place to start. And Society of Pediatric Radiology is very active in contrast-enhanced ultrasound as well, and they have fantastic resources on their websites. And with that, I want to thank you for your attention, and if you have any questions about technique, would be happy to answer.
Does anyone have any comments or questions about that technique? That was very good, Andrej. We enjoyed it.
Yeah.
So I apologize. We've asked for a roving mic, but we don't have it yet.
Yes.
Speak up. Yes?
No, you don't inject little, flush little. No, you give your dose and then you flush. So the question is, she said that her cardiac colleague
come here.
said if...
Mike,
There's a mic.
right here.
All right. So a technique that is used for cardiac contrast enhanced ultrasound is different from what we use for abdominal and other applications. In cardiac echo, they want to have really tight, concentrated bolus to opacify large glob of blood in a ventricle to see the borders and also to see holes. So this is a little bit different. We want to inject contrast quickly, but we don't want to hammer it because they really don't care about the dose they deliver. If they lose 20–30% of their dose, that's fine. But they want to have tight bolus. We want to inject as many bubbles as we can and let them last for as long as possible. So we do relatively quick injection over, let's say, 2 seconds, and then you flush it about 2 mL per second. You don't want to do little by little, then you ruin your bolus and you're not going to have as avid arterial phase contrast enhancement as you would with this technique. So honestly, this works just fine.
Yeah. Go ahead.
Yeah, and another thing is, too, you've got a big chamber. If you inject the bubbles very fast, you have such a high dose of bubbles that you get all shadowing. So we like to have a very tight bolus that we can get a good enhancement because we don't have that problem. We don't have a big empty sac that the bubbles are going to go in. They're kind of diffused. So in cardiology, you don't want that high, big bolus because then you'll end up with all that shadowing.
Hey, Richard, explain what you mean by a tight bolus.
No, we don't want to inject very slowly that we get very low enhancement. We want to see a nice, sharp bolus so we get a very nice arterial phase enhancement. If you do that in the heart, there's so many bubbles in that big heart chamber that you just get shadowing, so you'll lose all your information. So the injection for cardiology is different than what we use for abdomen.
But, so Andrej actually gave a rate of injection, and I don't know exactly what that rate is, but I'll make a comment about, you showed beautifully, so in all of Andrej's demonstrations that he made with all 3 of the contrast agents, he shows the way we want to ideally set up the 3-way stopcock. And that is for the contrast agent to go in the straight port and the flush always to go around the corner. Peter Burns would always say to me, don't make those bubbles go around a corner because you'll destroy some of them. But so if you have a nice IV system and if you've done what Andrej says, like you've kept your stopcock closed to the contrast agent and then you put on your flush, it's nice to flush it just to make sure that everything is open. It's very easy to leave that additional little close that often is right next to the patient's arm closed. And of course, if you push the contrast agent against a closed stopcock, you will destroy all those bubbles that you have in that syringe. So you want to make sure that your technique is good. But actually, I think it's really important what we're talking about. And so certainly when you're doing an abdominal scan, you want to have a bolus arrive, what Richard called a tight bolus. And so once we make sure that everything is fine, we don't push it in, like we don't jam it in, but we do inject it fairly fairly efficiently and promptly. And then it's when we say start flush that we're going to start our timer. And so it's when that flush goes in that the contrast is actually really delivered to the patient. And so you want also not to have that flush go in slowly. So we quite expeditiously inject the agent.
And one thing I forgot to mention, our hospital just purchased line connectors with filters in them. So if you have a filter in your line, it will filter all your microbubbles.
Yeah.
So if you inject and you see nothing, there is probably a filter somewhere in the line. So disconnect it, inject straight into the IV line, and you'll be just fine.
Was there another question? If not, we'll, oh yes. Yeah, so the question is, she said if you mucked up. I don't think you said that exactly, but that's how I interpreted. But so if something goes wrong with your injection, sometimes you can figure out what you've done or what's happened, but you don't always know. And so yes, we do, of course, we re-inject. And if your injection's not good, never interpret the data. Like in other words, if you don't have a nice bolus and you don't get good enhancement, you don't want to be doing your interpretation on that. So yes, we do re-inject. And actually, both Richard and Andrej, you can answer this question. So we always draw up what we anticipate we'll probably use right into the syringe. So we rarely go back and then re-aspirate from the vial. Is that true for you?
Sometimes you might end up with when you draw microbubbles from the vial, you might end up with a little bit more than you need in your syringe, which is fine. And then we just slowly inject it back. But do it slowly without applying too much pressure, otherwise you're going to ruin your microbubbles.
Yeah, and actually, so there's a difference. You know, keep in mind that we live thousands of miles apart, and he's a Russian, and I'm a Canadian.
Two strikes, two strikes.
But so we, for example, whatever we've taken out of the vial, we never put it back in. So we don't put it back in. And also, just for comment, so we also don't, I haven't vented. We used to vent the vial when we started, but I don't think I've done a venting on a vial for, I don't know, 15 years probably.
It's a good technique when you're just starting. After a few years of experience, can stop. But I only draw the dose in a syringe that I need to inject because I want to give this syringe to my sonographer or resident or whoever is injecting and tell them inject everything. I don't want them to have 5 ml of Lumazone in the syringe and then in a dark room look at with the microscope at those lines and inject only 1.2 if that's what I need. It's just easier for me to draw 1.2, give it to them, I said, everything goes in, and it's just easier for me. But again, it's whatever works for your particular.
That's good. Thank you so much, Andrej. That was terrific. So we'll go to our next.